Hello everyone, my name is Dr. Arun Prasad, and in this session I have explained about the peripheral nervous system. So the first part will start with the cranial nerves. I have explained all the cranial nerves, various functional aspects, and moreover I have showed all the cranial nerves and their locations and the target organs, everything in the form of animations. Okay, hope you guys will benefit from this video. In case if you have any queries, any doubts, please feel free to write to me, and let's start with the session now. Okay, if you look at the learning objectives, you will be studying about the functions of the peripheral nervous system and its components, understand various type of sensory receptors and how the sensory informations are processed, and understand the functions of nerves, ganglia, cranial nerves, and the spinal nerves, and describe the structure of motor endings and explain how motor activity is taking place. Explain the reflex arc mechanism and its component. Okay, so these are the learning objectives. We will be going through it. And coming to the structure of peripheral nervous system, you have to know that you will be studying only about 12 pairs of cranial nerves and 31 pairs of spinal nerves. Okay, in central nervous system you would have studied about the whole brain as well as the spinal cord. Okay, their structures, their pathways, then tracks, then various supportive structures, etc. Likewise, in peripheral nervous system there is motor as well as sensory divisions. Okay, motor divisions means from the brain and spinal cord, the sensory the impulse that comes to through the motor nerves, it reaches the target organs, whereas the sensations like pain, touch, pressure, heat, cold, every sensations will go from the periphery organ towards the nerve, through the nerve to the brain and spinal cord. Okay, so in this peripheral nervous system, we will be discussing about only 12 pairs of cranial nerves and 31 pairs of spinal nerves. When I say about the word pairs, that means what? This whatever nerve present in the right side of the body is also present in the left side of the body. Whatever branches they have in the right side, they also have the same branch in the left side of the body. Okay, there are 12 pairs of cranial nerves and 31 pairs of spinal nerves. You would have seen here autonomic nervous system. If you look at the word autonomous, that means free functioning. Okay, in this 12 pairs of cranial nerves and 31 pairs of spinal nerves, there are some nerves which is functioning autonomously, okay, without your control. For example, you take example heartbeat, you are not controlling it. You take for example stomach movements. Okay, the food movement that is taking place in the intestine, you are not doing it. It is working automatically. Okay, take kidney, the flow of urine, kidney is filtering the urine, the flow is coming through the ureter, then it is taken to the bladder. Fine, it is taking without your control, it is taking place without your control. So these are all, we call it as autonomous nervous organ. Okay, these are all organs that is supplied by the autonomic nervous system, that in fact we will discuss that in depth, which has sympathetic and parasympathetic divisions. Okay, so when the heart is beating fast, that means the sympathetic nerves is stimulated. When the heart is beating slow, that means the parasympathetic nerve is stimulated. So we will discuss in depth about this under the objective of autonomic nervous system. Okay, so let's go to the next topic, next slide. So if you come into this peripheral nervous system, as I told you, these are the network of nerves that is present. in the complete body. It is distributed all over the body, which is the peripheral nervous system. We divide it into somatic nervous system and autonomic nervous system. Okay, so there are a group of nerves in the cranial nerves that is taking the name as autonomic nervous system. There is a group of nerves in the spinal nerve that is taking name as autonomic nervous system nerves. Okay, so we will see that one by one. Okay, just remember that we now in peripheral nervous system we are going to study about this 12 pairs of cranial nerves and 31 pairs of spinal nerves. Okay, so here the somatic nervous system is also called as voluntary nervous system. Okay, suppose when you want to lift a cup of coffee, it is voluntary. Okay, you are doing it under voluntary control. Okay, so if some nerves that is working without your control, like nerves that is supplying the heart to increase and reduce the heartbeat, it is involuntary nervous system. That's what we call it as autonomic nervous system. Okay, so remaining all the nerves that is distributed to other various muscles, bones, tendons, ligaments, skin, all these are coming under somatic nervous system. Okay, so in somatic nervous system you have sensory and motor nerves. Okay, so whichever nerves that is taking the impulse from the periphery, example from the skin towards the brain, we call it as sensory nerves. Okay, if there is a bee sting, the pain from the sting area goes towards the through the nerve to the brain. So these are all the sensory nerves. Okay, whereas you lift 5 kilo weight, that means what? The impulse is coming from the brain and spinal cord towards the muscle through the nerve. These are all the motor nerves. Okay, so this is a difference between sensory and the motor nerves. So likewise, if you look at the autonomic nervous system, it is supplying the smooth muscles, glands, all the visceral organs. Say, okay, visceral organs like involuntary movement in response to unconscious sensory inputs such as heart rate, respiratory rate, digestions. Okay, all these are regulated by the autonomic nervous system. Who the hypothalamus is the boss of all this autonomic nervous system. Okay, that you would have studied. Through these autonomic nerves, the hypothalamus is controlling the visceral organs like heart, stomach beat, stomach movements, heartbeat, and all this stuff. Okay, so in this autonomic nervous system, you have the sympathetic and parasympathetic, but in fact, we will separate that in depth in the autonomic nervous system. This is just a outline. Okay, a nerve. What is a nerve? It's a cord-like organ that's a part of peripheral nervous system. There are 12 pairs of cranial nerves and 31 pairs of spinal nerves. Right. So difference between myelinated and non-myelinated is whatever axon, that is a nerve fiber that is covered by myelin sheath, we call it as myelinated nerve fibers. So whatever axon that is not covered by myelinated sheath, we call it as non-myelinated nerve fibers. In fact, the full, I mean maximum number of almost all the nerves are myelinated nerve fibers. Okay, so most of the nerves in the body are myelinated nerve fibers. Coming to the structure of the nerve, the microscopic structure of the nerve, I would like to show you the small microscopic structure of the nerve. What you see here is a cut section of the nerve. So when you look at this nerve closely, the outermost layer, there is a connective tissue sheath. We call it as a epineurium. Okay, we call this connective tissue sheath as the epineurium. Okay, so you can see here. Okay, this is the epineurium, the outermost connective tissue. On this, you have the small blood vessels. Okay, these are all called as vasa nervosum. Okay, these are all the small microscopic vessels that is supplying the nerve. Okay, we call this as vasa nervosum. So inside this nerve, if you look at the cut section of this nerve, if you look at the cuts, there are a lot of blocks. There are lot of blocks. So this block junction covering is called as a perineurium. The epineurium is also a connective tissue. The perineurium is also a connective tissue. Okay, so inside the perineurium there are multiple small nerve fibers. We call that as endoneurium. This is actually the axon of a cell, of the neuron cell. Okay, so these axons are covered by this myelin sheath. This is the actual axon. These are the myelin sheath that is covering the axon. So if you look at this nerve section, you can see there are many number of axons. You can see there are n number of axons. That means what, these many neuron axons are passing through the nerve. Generally there are around 70 to 140 axons that is traveling on an average in the nerve. Okay, so when the nerve is cut, we are not disturbing the nerve cell body, we are just only cutting the axon of the cell. Okay, but these nerve cell bodies are located in the ganglion. So we will see in the cut section of the spinal cord where is ganglion, and from the ganglion how these axons are traveling. So these are all the microscopic structure. We can see the small blood vessels. These are also called as the vesicular arteries and the veins. Okay, so these blood vessels, they supply the uh, nerve structures. Okay, so when the nerve is cut, we are cutting the axon of each nerve cell, and thereby there is no chance of reunion. There is no chance of reunion. Okay, you know already that there is no multiplication process for nerve cells. Once the nerve cell is damaged, the damage is permanent. Structure what you see here is the cut section of the nerve. This is the structure. What you see here is the cut section of the nerve. And here you can see the perineurium, sorry, epineurium, perineurium, and the endoneurium. The endoneurium is actually the nerve fascicles, which is covered by the myelin sheath, and these are the blood vessels that is passing inside the nerve. So this is how you have to understand about the cut section of the nerve. As I told you, any nerve you cut, you are cutting the axons and you are seeing in the microscope. Okay, so coming to the structural classification of the nerve. The peripheral nervous system has sensory nerve and the motor nerve. The sensory nerve is also called as afferent nerve. The sensory nerve is also called as afferent nerve. The motor nerve is also called as the efferent nerve. So these nerves are classified according to the directions in which they transmit. So a mixed nerve are nothing but a single nerve that is working like a sensory nerve and also a motor nerve. Okay, this is what we call it as mixed nerve. That means what, this nerve has both sensory fibers as well as the motor fibers. So most of the nerves in the peripheral nervous system are mixed nerve, which functions as both sensory, that is afferent nerve, as well as the motor, that is the efferent nerve. Okay, so this is what you have to understand basically. So the mixed nerve of carries both sensory as well and motor nerve fibers. Okay, so the ganglion is the collection of nerve cell bodies associated with the nerve. Okay, so the nuclei is present inside the. If you would have studied about the structure of the neuron, okay, the nerve cell, the neuron is a structural and functional unit of nerve cell. You would have studied about the structural aspect of the neuron. So in that, the nucleus is present in the cell body, and the continuation of the cell body is axon and the dendrites. Okay, so these axons are running in the nerves. So the ganglia is associated with the afferent nerve, contains cell bodies and sensory neurons. Okay, so the ganglia associated with the nerve fibers contain cell bodies and the autonomic motor neurons. Okay, so here you can see the cut section of the nerve. You can see the cut section of the nerve. Okay, this is the cross section of the mixed peripheral nerve. Okay, so the same, all the nerve has the same axons, that is axon fibers, that is the neuron fibers that is traveling in the nerve. Okay, so this is how a cross section of the nerve looks like. Generally in histology study, we don't strain the nerve with hematoxylin and eosin because nerve cell doesn't absorb the hematoxylin and eosin cell, because the nucleus and on the cell body is present in the ganglion. So the nerve is carrying only the axon fiber. So we use a special type of stain called silver stain to study the microscopic structure of the cross section of the nerve. Okay, so that we will discuss in histology. Coming to the cranial nerves, as I told you, since these nerves they originate inside the cranium, we call it as cranial nerves. Since these nerves they originate inside the cranium, we call it as the cranial nerves. So the order of the cranial nerve is important. Okay, the order follow comes like this: olfactory, optic, oculomotor, trochlear, trigeminal abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. So for example, if we say cranial nerve 10, it is vagus nerve. If we say cranial nerve 7, it is facial nerve. Uh, if we say cranial nerve 2, it is optic nerve. If we say cranial nerve 3, it is oculomotor nerve. So this order is important. Why this order is important? Because when you remove the brain from the skull, cranial fossa, first you will cut this optic nerve, then you will cut oculomotor, then trochlear, trigeminal, abducens. Then when it comes to this cerebral peduncle, all these nerves are arranged in this order. That is why we give the cranial nerve these numbers: cranial nerve 1, 2, 3, 5, 6, 7, 8, 9, 10, 11, 12, like this. Okay, so this is how we name the cranial nerves. Okay, so and the order is important. Order is olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. These are the 12 pairs of cranial nerves. They take the name as cranial nerve because they are originating inside the cranium. They are originating inside the cranium. So now what we will do is we will go into the cranial nerves and see one by one nerves. Okay, now we are going to look into 12 pairs of cranial nerves. Okay, we always divide the body into right half and the left half. So in one side, whatever nerves you have, it is present in the other side also. Well, for the cranial nerves, as I told you, since these nerves are originating inside the cranial cavity, we call them as cranial nerves. Okay, and that's what we're going to see one by one now. So, you know, this is a cranial cavity. This is a cranial cavity. Let me remove a bone. For example, I'll remove the temporal bone. Okay, this is a cranial cavity. In this place, you have all the neural structures. Okay, okay, fine. So what you see here is the dura mater, and what you see now here is the arachnoid matter, and that's the cerebrum, right half of the cerebrum. Okay, so to see the cranial nerve, we will go the cranial nerve according to the order. So first is olfactory nerve, which is responsible for sense of smell. Okay, so you always feel the smell inside the nasal cavity. You always feel the smell inside the nasal cavity. So the nasal cavity is present in this place. The nasal cavity is present in this place. This is the nasal cavity. So this is the place where the nerve has to be distributed in order to detect the sense of smell. Okay, so this is the nasal cavity. So when you look at this area, you need to go. This place is the nasal cavity where you have the nasal mucosa. In this place only the olfactory nerve is spread. So in order to see the olfactory nerve, I have to remove some bones. I will remove the maxilla, and I have to uh, locate the ethmoid bone. I have to locate the ethmoid bone, and this is the ethmoid bone. This is ethmoid bone. I will remove this eyeball also. Let me remove this eyeball also. So what you see here is this ethmoid bone. Okay, I will remove the frontal bone also. And here you see this is a ethmoid bone. This is a ethmoid bone, and this is the olfactory bulb, and this is the olfactory nerve. Okay, so I will select all these structures. I will select all the structures, and then okay, so Fine. So what you see here is in the base of the frontal lobe, the olfactory nerve is originating here. The olfactory nerve is originating here. So this is called as the olfactory nerve. This is the first cranial nerve. It originates in the base of the frontal lobe, and it goes all the way straight. And you see this is the ethmoid bone. This is ethmoid bone, and this is the perpendicular plate of ethmoid bone, and this is the cribriform plate of ethmoid bone. What you see here is the cribriform plate of ethmoid bone. Okay, if you observe here carefully, if you observe here carefully, this olfactory nerve in the base of the brain comes and ends as olfactory bulb. This is a olfactory bulb. So in this bulb, if you observe, there are a lot of branches. Okay, so you have the right nerve here and you have the left nerve here. In this is a cribriform plate. Okay, where you can see lots of minute holes, for around 15 to 16 minute holes are present in the cribriform of ethmoid bone, and this projection is called as a crista galli, to which the dural venous sheath is attached. Okay, so if you observe here carefully, uh, okay, now I want to go back and I want to select some more structures. Okay, so if you observe here carefully, you can see there are lots of fine branches of this olfactory nerve. Okay, that is piercing the ethmoid bone here. Can you see? Yeah, these are the small branches of the olfactory nerve that is piercing the cribriform plate of ethmoid bone, and then later it is coming to the nasal mucosa in this region. So these are all the concha bone, which is present to increase the nasal mucosal surface, which is present to increase the nasal mucosal surface. Okay, so what you see here is this is purely a sensory nerve. This is purely a sensory nerve. When the smell comes and hits this nasal mucosa, the smell is perceived by the small branches of this olfactory nerve. Then the impulse comes to the olfactory bulb. From the olfactory bulb, this sensation goes all the way down to the frontal lobe, where the olfactory nucleus is present. This is a place where the olfactory nucleus is present in the base of the frontal lobe. Okay, so this is purely a sensory nerve. Okay, then let's go to the optic nerve. The optic nerve is a second cranial nerve, and it is also a sensory nerve. It's also a sensory nerve. So for that, I will show you the diagram. Let me draw one diagram, then I will okay, just before that, see the parts. Okay, so this is the eyeball. Okay, this is the eyeball, and in the posterior aspect of the eyeball, you can see the nerve is piercing. The nerve is piercing in the posterior aspect of the eyeball. The nerve is piercing in the, so let me start from the beginning. Okay, so what you see here is the optic cavity, and I will remove this zygomatic bone and this sphenoid bone to show you the optic nerve. Okay, here you see the dural sheath is covering the optic nerve. The dural sheath is covering the optic nerve. So whenever there is a intracranial pressure, there is a edema of the optic nerve also, because of this dural sheath extension, because the dural sheath is extending all the way through this. The dural sheath is extending all the way through this. Okay, now I will remove the bones. I will remove all the bones, and you see, okay, when I remove this dural sheath, you can see the optic nerve clearly. Okay, here what you see here, this is the extension of this optic nerve. This is the extension of this optic nerve here. Okay, I will remove the dural sheath. Now you see this is the optic nerve. This is right optic nerve, and this is the left optic nerve, and this is the right ball and the left eyeball. Okay, Now when I isolate, you can see this optic nerve is entering in the posterior aspect of the eyeball. This optic nerve is entering into the posterior aspect of typically it is also covered by this it is also covered by the dural sheath. Okay, so if you see here, both this optic nerve will go and cross in this junction. Okay, at the okay, okay, you can see here. Okay, okay, so this is the optic nerve crossing junction, and that's called as a optic chiasma. That is called as the optic chiasma. Okay, so here you can see, um, yes, you see the optic nerve that is coming here, and at the uh, pituitary stalk level, I mean where the pituitary stalk is entering, the optic nerve is crossing. Okay, and the crossing junction is called as optic chiasma. From this place, it is going to the posterior aspect of the brainstem, that is called as the superior colliculi. This bulge is called as the superior colliculi. So the optic nerve tract fibers, it comes to superior colliculi. From this place, the neurons are connected to the occipital lobe. From this place, the neurons are connected to the occipital lobe. Now you have to understand one small thing. So let me draw a small diagram so that you will be able to understand the optic tract. Okay, this is the right eyeball, and this is the left eyeball. Okay, this is the left eyeball. So this is the right optic nerve coming to the optic chiasma, and from there it is going to the opposite side. Okay, and this is the left optic nerve coming to the optic chiasma, and then it is going to the opposite side. So now what happens, imagine there are 100 axons in this, there are 100 axon in this, there are 100 axon in this, and there are 100 axon in this fiber. So here you have the right occipital lobe, and this is the left occipital lobe. This is the left occipital lobe. Okay, so what you have to observe here is this optic nerve that is coming, the this is the right side and this is the left side. Okay, the optic nerve that is coming in the right side, coming all the way here at the optic chiasma, it is dividing into two, that is 50 axon goes in the opposite axon fibers, that is going to the opposite side of the occipital lobe, and the remaining 50% of the optic fiber, that is coming to the same side of the occipital lobe. Likewise, in the left eye, the 100 example 100% of the fibers are coming, then it is dividing into two, and 50% of the optic nerve fiber goes to the opposite side, and 50% of the optic nerve fibers comes to the same side of the occipital lobe. Okay, now what happens? Suppose if a person has injury to the occipital lobe, okay, for example, if the nerve is cut here in this junction, what happens? There will be complete loss of vision in this eye. Okay, or if the nerve is cut here in the left optic nerve, there is complete loss of vision in the left optic nerve eyeball. Okay, if there is any tumor, for example the pituitary tumor that is compressing the optic chiasma, okay, or any aneurysm around the circle of Willis. So around this you have the circle of Willis that we will discuss separately about the blood supply to the brain. So if there is any tumor compressing this area, then both the eyes will have vision loss, both the eye will have vision loss. For example, if there is any damage in this area, so what happens, 50% of the eye in retina is visible in this eye, and 50% of the retina is functional in this eye. Okay, that means what happens? That means what? The patient will look confused. We call it as hemianopsia. We call it as hemianopsia. All right. So likewise, so suppose if there is any bleeding in the occipital lobe, okay, and the whole occipital lobe is damaged, then also the patient suffers hemianopsia. So before the optic chiasma, if there is any optic nerve fiber damage, it leads to hemianopsia. If there is optic nerve fiber damage after this optic chiasma, this is optic chiasma. This is optic chiasma. So if there is any damage in this optic chiasma level, there is vision loss in both the eye. Okay. So if there is damage in this level from the eyeball till the optic chiasma, then the respective eyeball will lose the vision. Okay. So this is the optic tract mechanism you have to understand. That is, the nerve fiber of the right side comes to the optic chiasma, divide into two branches. So 50% of fibers goes to the same side of the occipital lobe, and 50% of the fiber comes to the opposite side of the occipital lobe. So this is what you have to understand. Apart from this, there are infectious diseases like herpes neuralgia, okay, where the viral herpes zoster virus affects the optic nerve and that leads to blindness. Okay, likewise there are many conditions where there is blind loss, vision loss, okay, that leads to blindness. We will discuss in the pathology, but here this is a mechanism, so you have to understand this mechanism in this place. You need to understand this mechanism in this place. Okay, so coming here, let's go to the application. Yeah, so this optic nerve is a pure sensory nerve. This optic nerve is a pure sensory nerve, and this nerve comes into the eyeball and it is spreading all over the retina. And when the light image goes, and see, when we discuss about the eyeball, we will separately see what are the different layers of cells that is present in the retina, and how these photoreceptor cells work. Okay, what are the different types of neurons present in the retina, we will discuss this when I am teaching about the eyeball. Okay, so now there are some other interesting thing you have to understand. You have to understand how this optic nerve is passing through this supraorbital foramen. Okay, that you have to see. If you see here, um, this is the optic eyeball. Okay, so I will keep the skull, and you see the eyeball is present in the orbit. Okay, we will look from the upper aspect. We will look from the upper aspect. Okay, so I will remove some of the bone. I will remove some of the bone and some bone here also, so that it will be clearly visible for you. Okay, so now if you see, this is the eyeball, and if you look at the muscles around the eyeball, if you look at the muscles around the eyeball, okay, these are the superior rectus muscle, this is the lateral rectus muscle, and this is a medial rectus muscle, and this is the inferior rectus muscle, and this is a superior oblique, and this is the inferior oblique muscle. So common tendinous origin, these muscles have a common tendinous origin. Okay, so you can see here. Okay, so you can see this is a central tendinous ring. Okay, so this ring only all these extraocular muscles are attached, and in this tendinous ring the optic nerve is entering, and then entering into the eyeball, entering into the eyeball and spreading on the retina. Okay, so this is what you have to understand. This is what you have to understand. So when you look at the ocular movements, I would have discussed this in the muscular system, like the eye, when this respective muscle contracts, the eyeball goes up, down, medial side, lateral side, and for clockwise and anti-clockwise rotation, this superior rectus and the inferior rectus muscles will work. Okay, so this is now the optic nerve is reaching the eyeball. So if you see here, this is called a supraorbital foramen. This is called as the supraorbital foramen. Okay, I will remove the eyeball. Okay, here you can see there is the this is a supraorbital foramen, and here you have other nerve also that is entering. We will discuss this one by one. Okay, we will discuss this one by one, and the optic nerve is entering through this supraorbital foramen of this sphenoid bone. Okay, you can see this is okay. Now let's go to the third terminal, oculomotor. Okay. So oculo means eye, motor means movement. So this nerve is a third cranial nerve, and it is coming under the parasympathetic nerve. Okay, the third cranial nerve. It is also working as a motor nerve and the sensory nerve. Okay, so this is the nerve that is supplying around the eyeball muscles and all this stuff. So this is what we are going to see now. Okay, so let's think about the third cranial nerve, the oculomotor nerve. Third cranial nerve, the oculomotor nerve. Okay, so now if you see in this place, I have to keep this extraocular muscles in place. Okay, okay, fine. Now I will show you the. Okay, this is the oculomotor nerve. This is the oculomotor nerve. So this oculomotor nerve, it is supplying the extraocular muscles. It is supplying the extraocular muscles, and it is the parasympathetic nerve. And the parasympathetic function is to supply this iris, okay, for uh, accommodation of the vision. Okay, so now if you see, what you see here is the oculomotor nerve that is coming out through this orbital foramen. Okay, that is coming out to the orbital foramen, and this oculomotor nerve, this branch is supplying the superior rectus muscle, and this supplying the inferior rectus muscle, and this branch is supplying the medial rectus muscle, and it is this muscle is also supplying the ciliary muscles of the eye and the circular muscle fibers of the iris. So this is a parasympathetic function. This is a parasympathetic function. So in parasympathetic function, if you see the function of this oculomotor, that is the third cranial nerve, is to constrict the pupil, okay, whereas the sympathetic nerve that is coming from the thoracic output, we will discuss that autonomic nervous system separately, that will dilate the pupil. Okay, so the oculomotor nerve, there are some parasympathetic branches, that is supplying the iris. So I want to show you the ciliary ganglion. Okay, this ciliary ganglion is formed by this oculomotor nerve. This ciliary ganglion is present in the posterior aspect of the eyeball. Okay, so this is the ciliary ganglion. This is the ciliary ganglion. What you see here is, this is the ciliary ganglion. This ciliary ganglion is a branch that is formed from this oculomotor nerve. This ciliary ganglion is just located in the posterior aspect of the eyeball, and that is the uh, branch from autonomic branch from this oculomotor nerve. Okay, and this nerve from the ciliary ganglion, it goes, the branch goes to the iris for constriction of this pupil, okay, whereas the sympathetic nerve, it does the opposite function. So this is what you have to understand, the oculomotor nerve function. It's a third cranial nerve. It functions to move the eyeball. It is supplying the superior rectus, inferior rectus, and medial rectus extraocular muscles, and also the ciliary muscles and the circular muscles of the iris bone. Okay, so this is what you have to understand about the oculomotor fiber. Next, we'll go to the trochlear nerve. That's the fourth cranial nerve. Okay, it is starting in the cerebral aqueduct. I mean, in the floor of the midbrain. Okay, where the cerebral aqueduct starts. So what you see here is this muscle, this nerve is supplying the superior oblique muscle. Okay, if you see this muscle, okay, this is the superior oblique muscle of the eyeball. Yeah, this is the superior oblique muscle. This is the superior oblique muscle, and this muscle is supplied by this trochlear nerve. Okay, you can see here. Yeah, this is the trochlear nerve that is coming to the orbital foramen. So you can see this is the trochlear nerve. Okay, that is also coming to the orbital foramen, and it is supplying the superior oblique muscle. Okay, so the function is to move the eyeball in the clockwise. You know, the superior oblique and the inferior oblique muscles of the eyeball will rotate the eyeball to the right. Okay, then you have the fifth cranial nerve, the trigeminal nerve. This is one of the thickest cranial nerve. This is one of the thickest cranial nerve, and the complete sensory supply of the face is done by this trigeminal nerve. The complete sensory supply of the face is done by this trigeminal nerve. For that, I will remove this uh, dura mater. Okay, so the trigeminal nerve starts from the pons. Okay, and most of the nerve is starting from the pons area. Okay, you can see this is the trigeminal nerve. This is the trigeminal nerve, and you can see how thick it is. Okay, it is, you can see how thick it is. Okay, now if you see here, this is the origin point of the trigeminal nerve. Okay, then it is coming and forming a big ganglion. It is a thickest cranial nerve. The trigeminal nerve is said to be the thickest of all cranial nerve. Okay, and it divides into three main branches. One is the ophthalmic branch. We also call it as V1, and one is the maxillary branch. We also call it as V2, and third is the mandibular branch. We call it as V3. Okay, we can also call it as V3. So now if you look at the dermatomal level, like for example the sensory supply of the face. Okay, so okay, you can see the V1 nerve distribution is in this place, the V2 nerve distribution in this place, and V3 nerve distribution in this place. Okay, there are also motor fibers in the trigeminal nerve which is supplying the muscle of mastication, the I mean this muscle that is responsible for chewing the food, masticate muscle, the masseter and the buccinator. Okay, so the V1 nerve is distributing in this area. Suppose if there is any wound here, the pain goes through this V1 nerve route through the trigeminal nerve. Okay, then if there is any dental caries in the upper jaw, the pain impulse goes to this V2 nerve branch, that is the mandibular branch, to the trigeminal nerve. If there is any dental caries in the lower jaw, the pain impulse goes through the V3 branch, that is a mandibular branch, to the trigeminal nerve, and then it goes to the brain. So this is what the dermatomal pattern. So now we will see how this nerve is supplying the teeth. For example, if I keep the teeth here, okay. Now I want to show you the teeth. Uh, yeah, see, there is severe amount of dental pain. Okay, people are really affected by this dental pain. Okay, so for that, what I will do is I will remove this bone. Okay, I will remove this bone, and you see these are all the branches that is entering into the dental aspect. Okay, couple of teeth. Okay, okay, and you see This is how the mandibular branch is maxillary branch is coming and entering into the dental root. Okay, so when there is dental caries, this decayed tooth will go and affect this tip of this trigeminal nerve. Okay, and this trigeminal nerve carries severe amount of pain impulse. Okay, so there are people who suffer too much because of dental pain. Okay, so this is the mandibular branch, okay, maxillary branch. And here I want to show you this mandibular nerve distribution also. And you can see this is the dental premolar, premolar and canine tooth. And if you see in this place you have this. Yeah, you see. Okay. Okay, so this is the branch, mandibular branch. It comes and inserts in all the dental sockets, and this is a maxillary branch. It comes and inserts into all the socket, and all this branch and joins at the trigeminal ganglion in this place. At the trigeminal ganglion in this place, from the ganglion, the nerve is going to the pons. Okay, so you have to know this. This trigeminal nerve is supplying the complete sensory supply to the face area, the V1, V2, V3, the dermatomal pattern that I have shown you. Okay, now, uh, uh, generally for giving for tooth extraction, we give general anesthesia. I mean, not general anesthesia, local anesthesia by the side area. Now, you know the location of the nerve and you know where to block it. Okay, so this is how the trigeminal nerve, that you will discuss that in clinical aspect. So this is how the trigeminal nerve is distributed, and this trigeminal nerve is going into the brain, the pons area. And you know what? The trigeminal nerve is said to be the thickest nerve. We can see all the place here. Okay, now we can see this is the distribution of the trigeminal nerve, the ophthalmic nerve branch coming here. Okay, so coming to the point, it is supplying the muscles of mastication. So what are the masticatory muscles? As I told you, there is buccinator and the masseter. Okay, so if you look at the muscles here, okay, this is the masseter muscle. This is a masseter muscle. If you look at the nerve supply, the masseter muscle is supplied by this. See, this is the trigeminal nerve, and the masseter muscle is supplied by the branch of this trigeminal nerve. The masseter is supplied by branch of this trigeminal nerve here. Okay, so this is a masseter and the buccinator. I will show you. Okay, you can see this is a branch coming from the trigeminal nerve that is supplying the masseter muscle. Masseter muscle is supplied by the trigeminal nerve. Okay, so coming here, this is what you have to understand about the trigeminal nerve. So let's go to the next sixth cranial nerve, that is the abducens nerve. This abducens nerve is supplying the lateral rectus muscle. This abducens nerve is supplying the lateral rectus muscle. I will show you. Okay. Okay. So this is the abducens nerve, I mean lateral rectus muscle. So when you look at the nerve supply here, this is the abducens nerve. Okay, that is also coming to the orbital foramen. You see what? The optic nerve is entering to the orbital foramen. Okay, then the oculomotor is entering through the orbital foramen. The abducens nerve is entering through the foramen, like 4 or 6 nerve that is entering through the orbit. Okay, that is the place where the eyeball is located. We will see all, even the facial nerve is coming to the orbit area. Okay, so there are 6 cranial nerves that is coming to the orbital area. You have to keep this in mind. Okay, so suppose for example if there is damage to the abducens nerve, this muscle will not work. Okay, this lateral rectus muscle will paralyze. So what happens, the muscle working in this side will try to pull this eyeball towards the medial side. So what happens, the person eye is always turning towards the medial side. We call it as a squinting. Okay, so let me show you this squint picture. So what you see here is the picture of a baby. Okay, the picture of the baby. So for example, if you in this eye, you see this is looking straight and this is turned towards the medial side. Okay, that is due to paralysis of the lateral rectus. Okay, that due to paralysis of the lateral rectus. Okay, if you see this picture, both the eyes are rotated medially. That means what, both the lateral rectus muscles are not working due to lateral rectus paralysis. Okay, and you can also see the oculomotor palsy means paralysis. Okay, so in this picture what you see, the superior rectus, the medial rectus and the inferior rectus are paralyzed. So what happened, the muscle that is working well in the lateral side is pulling the eyeball towards the lateral side. So this is called a synergy mechanism. Okay, if this guy is strong, he will be weak. I mean, if both are strong, the eyes will look straight. If this guy is weak, the medial rectus is weak and the lateral rectus is strong, that means what? The eyeball will be pulled towards that respective side. So this lateral squinting takes place in oculomotor nerve palsy, and the medial squinting is taking place in the abducens nerve palsy. Okay, so this is what you have to understand about the squinting of the eye due to paralysis of these nerves or due to damage to this kind of nerve fibers. Okay, so we will go to the next nerve. Trochlear is the fourth cranial nerve. I forgot to discuss about the trochlear nerve. Okay, so the trochlear nerve is supplying the superior oblique muscle. Okay, and this is the superior oblique muscle. What you see here is the superior oblique muscle. If you look at the trochlear nerve, yeah, this is yeah, trochlear nerve we discussed already, right? So no problem. So then let's go to the next nerve, that is the facial nerve, which is the seventh cranial nerve. Okay, facial nerve, that is the seventh cranial nerve. This facial nerve is more interesting because there are a lot of cases with facial nerve paralysis. Okay, see this facial nerve is originating in the pons. Okay, it is a mixed cranial nerve. It has sensory fibers, motor fibers, and it is also a parasympathetic nerve. Okay, so we will discuss this function one by one. So if you look at this facial nerve, if you look at this facial nerve, um, you know what? This is a seventh cranial nerve. It is having three parts. One is the part inside the cranium, we call it as intracranial part. Then it is passing through the temporal bone. Okay, this is the temporal bone. This is a temporal bone. So this is a temporal bone. It is passing through the temporal bone. So we call it as intratemporal part, and it is exiting in the temporal bone through the stylomastoid foramen. We call it as extracranial part. Okay, three part: intracranial part, intratemporal part, and extracranial part. So part of this facial nerve is present. Okay, let's see the facial nerve first. So as I told you, it's the seventh cranial nerve. Okay, so yes. Okay, fine. So now I have isolated this origin part. Okay, so here you see this is the intracranial part of the facial nerve. This is the intracranial part of the facial nerve. Okay, and then it is entering into the temporal bone. It is entering into the temporal bone. So from here till here, From here till here, it is the intratemporal part. Intratemporal part. From here to all side of the face, it is extracranial part. It is the extracranial part. Okay. The facial nerve is supplying the muscles of the face. The facial nerve is supplying the muscles of the face, and mm, if you look at the muscles of the face, facial expression, you see there are a lot of small muscles in the face. All these facial muscles are supplied. We divide this face into right half and the left half. We would have discussed about the muscles in the muscle lecture. So now coming to the intracranial part. Okay, so we will come step by step. Okay, so now what you see, I will uh, remove the facial nerve. Okay, okay, you can see this is the, yeah, this is the intracranial part of the facial nerve. It starts in the pons, and then it is coming to the sensory function. It is supplying the anterior two-third of the tongue. Okay, anterior two-third of the tongue is supplied by this facial nerve. It senses the sense of, detects the sense of taste. Then motor function is supplying the muscles of the facial expression. Supplying the muscles of the facial expression. Then autonomic function is, it is supplying the parotid gland. It is supplying the parotid gland. And whenever you see some delicious food or you smell some delicious food, automatically the salivation starts. So that is the function by the facial nerve. Okay. So now coming to this, the facial nerve, it is starting in the pons and it is entering into the temporal bone, the acoustic foramen, and inside the temporal bone, see, the that is the place where the uh, uh, organs of hearing are present. Organs of hearing, if you see inside the temporal bone, you have the internal ear, the vestibulocochlear apparatus, then the middle ear, you have the three occipital bones, malleus, incus, and stapes, and then the external auditory canal. Okay, so once this facial nerve enters this acoustic foramen here, once the facial nerve enters the acoustic foramen in this place, once the facial nerve enters the acoustic foramen in this place, so what happens? This facial nerve gives a small branch to a small muscle called as stapedius that is attached to the stapes bone. Listen, there are three bones, that is malleus, incus, and stapes. To the stape there is a small muscle fiber called as stapedius. This stapedius muscle fiber supplied by the branch of this facial nerve. Okay, it is supplied by the branch of this facial nerve. So that is why if there is facial nerve paralysis at the middle ear level, then there is paralysis of stapedius muscle and the patient experiences some ringing sound in the ear in the facial palsy. Okay, so uh, if there is paralysis in the, and so we will discuss about the pathology now after I show you the nerve. Okay, then after this middle ear, there is a small hole in the base of the temporal bone that's called as stylomastoid foramen. Okay, this is a styloid process. This, okay, this horn like structure is called a styloid process, and this projection is called as a mastoid process. In between these two, there is a small hole called as the stylomastoid foramen. Okay, this stylomastoid foramen is present the external auditory canal here. This is external auditory canal, and the stylomastoid foramen is present just as adjacent to that. So what happens? This nerve exits out through the stylomastoid foramen, and then it passes through the parotid gland. You have the parotid gland located in this place. I will show you that here. Okay, so this is a parotid gland. Okay, so this facial nerve, it is passing through the parotid gland here. It is passing through the parotid gland here. In the parotid gland, it divides into five branches. In the parotid gland, it divides into five branches. Okay, one branch is this the okay branch. This is the branch. It is supplying the temporalis muscle. Okay, then I will remove this parotid gland, then we will know. Okay, so this is the facial nerve. It is giving one temporal branch. Then this is the zygomatic branch. It is supplying the muscles of the zygomatic bone area, the zygomaticus major, zygomaticus minor, and the depressor nasi and all this stuff. Okay, and this is the uh, okay, the zygomatic nerve is finished. Okay, this is a zygomatic branch. Then okay, okay, let me go for multiple selection. Okay, this is a main facial nerve, and this is a temporal branch, and this is a zygomatic branch, and this is the buccal branch, where it is supplying the muscles of the buccal region. And this is the mandibular branch. This is the mandibular branch. This is the mandibular branch, where it is supplying the muscles of the mandible region. And here you have this small digastric branch. Okay, and also from this these are the mandible branch, and also there is cervical branch. Okay, there is cervical branch, and this is the posterior auricular nerve branch. Okay, now if you see these, there are yeah, and this is no. Oof. You see, these are the branches of the facial nerve. Okay, the temporal branch, the zygomatic branch, ma- buccal branch, mandibular branch, and then the cervical branch that is supplying the platysma muscle. Okay, so these many branches are present. So this is a place where the parotid gland is located. So if there is any parotid gland tumor removal, that leads to paralysis of the facial nerve, and the patient suffers from facial palsy, permanent facial palsy. So, so when this facial nerve is supplying all the muscles of the facial expression here, when this supplying all the facial expression here. In case if there is any depression to this stylomastoid foramen, you see, this is the stylomastoid foramen. This is the stylomastoid foramen where the nerve is exiting out. If there is compression due to sometimes the cold weather continuously flushes into the external auditory canal, that leads to narrowing of the stylomastoid foramen. Once the nerve suffers neuropraxia, it's a type of nerve injury due to nerve compression. So all the muscles in the one half of the face is paralyzed. All the muscles in one half of the face is paralyzed. Okay, now I will show you one picture of the facial palsy, so that you will be able to understand the difference between the normal muscle and the facial palsy. Okay, now we divide the face into right side and the left side. So this is the right and this is the left side. Okay, so what happens when we ask the patient to show the teeth, this side muscle is working, so the muscles are pulling this side of the face towards this side. So this is good side and this is paralyzed side. This is good side and this is paralyzed side. So like this, when you ask the patient to close the eye, what happens? One side, this side will close and this side remains open. This side it remains open. Okay. So what happens here? you have to understand that this half of the face is paralyzed due to the nerve compression of the facial nerve, and this side is working. So that's why you can see there is contraction of the muscles in this the working side. Okay, so this is how to diagnose. You have to ask the patient to close the eye and show the teeth to find out which side of the face is paralyzed. Mostly, most of my beginning first year students, they say, yeah, this side is good and this side is paralyzed. Okay, it's not. This side is working good. That's why when the muscle contracts, the synergy mechanism is pulling the face towards the uh, working side. Okay, so this is how the facial palpation appears. Okay, so let's go to the next nerve. The vestibulocochlear nerve. We'll go into the vestibulocochlear nerve. So this is the eighth cranial nerve. It's a sensory nerve. Uh, it is starting in the cerebellum, near the cerebellum, and the fibers are going to the temporal lobe, where the auditory functions are located. Where the auditory function is located. So when you hear about the nerve, vestibulocochlear nerve, that means it has to go into the vestibulocochlear apparatus. Okay, the vestibulocochlear apparatus is the internal ear. The vestibulocochlear apparatus is the internal ear that is supplying the nerve to the vestibulocochlear apparatus. Okay, so for example, um, when you speak the word vestibulocochlear, that means we divide the nerve into vestibule part and the cochlear part. So when you study about the internal ear, you will study about the vestibulocochlear apparatus, which will divide into vestibule part and the cochlear part. So here when you see, I am going to remove this temporal bone. Yes. Okay, here you see this is the, yeah, this is the nerve. Okay, fine. So this is a vestibulocochlear nerve. This is a vestibulocochlear nerve. Okay, this nerve comes into the temporal bone and divides into the vestibule part and the cochlear part. So this is the vestibule ganglion and this is the cochlear part. So this nerve divides into this vestibular part goes to vestibule part. Earlier, this nerve spreads around the cochlea. Okay, so when you study about the hearing mechanism, you know how the nerve cells in the cochlea are oscillating and how it is converting the auditory, I mean the mechanical vibration into nervous impulse. Okay, so this is a vestibular cochlear nerve. So it is, this nerve is present in the temporal bone. This nerve is present in the temporal bone. Okay, so okay, when there is sensory neural hearing loss, that means there will be damage to this vestibulocochlear nerve. Okay, so the vestibule part is supplying the semicircular canals, and the cochlear part is supplying the organs of Corti, and this nerve is responsible for body balance as well as sense of hearing. Through this nerve only, the hearing impulse is going to the temporal lobe. Okay, the hearing impulse is going to the temporal lobe. Next is the glossopharyngeal nerve, which is starting in the medulla oblongata. Okay, it is mixed nerve. It's a mixed nerve, and it is supplying the parotid gland and also the muscles of the tongue and pharynx. Muscles of the tongue and pharynx. If you look at the muscles of the pharynx, uh, if you look at the muscles of the pharynx, okay, now I will remove this. Okay. Okay, here. What you see here is this is the superior pharyngeal, I mean inferior pharyngeal constrictor muscle. Okay, and here there are superior pharyngeal constrictor muscle, inferior pharyngeal constrictor muscle. So what happens? This uh, nerve is a parasympathetic nerve. Okay, so this is supplying the pharynx area. This is the area where the pharynx is located. This is the area where the pharynx is located. Okay, now what you can see, these are the areas of the pharynx, and this. Okay, now what you see here is these are the pharyngeal area, and this is the inferior pharyngeal constrictor muscle. This is the inferior pharyngeal constrictor muscle, and this is the middle pharyngeal constrictor muscle. Okay. Now this is the middle pharyngeal constrictor muscle. This is the middle pharyngeal constrictor muscle, and this is superior pharyngeal constrictor muscles. Okay. So these muscles are innervated by the vagus nerve branch. Apart from this, if you look at this is the oropharynx. I will remove the tongue. This is the oropharynx. Okay, and here you have the nasopharynx. You have the nasopharynx in the nasal area. You have the this is the nasopharynx, and this is a laryngopharynx. Okay, these areas are innervated by this glossopharyngeal nerve, are innervated by the glossopharyngeal nerve. Imagine this is an important junction. Okay, so whenever you swallow the food, when you this epiglottis should close the respiratory passage and allow the food to pass through the esophagus. Okay, this epiglottis will you will stop breathing. This epiglottis will close the respiratory passage and allow the food to pass into the esophagus aspect. Esophagus. This is the esophagus. This is the esophagus. Okay, and this is okay. Yeah, what you see here, this is the esophagus and this is the respiratory passage. So what you do, this epiglottis, this piece of cartilage is called as epiglottis. This piece of cartilage is called as epiglottis. So whenever you swallow the food, this epiglottis will close this respiratory passage and allow the food to pass in the posterior aspect of esophagus. So this anatomy is very important when you are putting the nasogastric tube for feeding the patients who are unconscious or semi-conscious or unable to swallow or whatever it is. Okay, make sure you don't insert the nasogastric tube inside the respiratory trachea. Okay, so whenever you insert this nasogastric tube, ask the patient to swallow so that this epiglottis will close the respiratory passage and the tube goes to the esophagus here. Okay, sometimes it will go for unconscious patients, the tube goes to the trachea, and if you don't remove the tube, it will be a disaster. Okay, by the patient will die of aspiration. So that you will learn clinical in the clinical area. Okay, so now these are the pharyngeal. These areas are supplied by this glossopharyngeal nerve, and it is also supplying the tongue, and it is also helpful in salivation, as well as when you swallow the food, automatically the epiglottis closing the respiratory passage. So these are all the autonomous function. Okay, You are not doing this function. Automatically it is done. That is why we call it as autonomic nerve system nerve supply. Okay, so this is a glossopharyngeal nerve. Yeah, this is the glossopharyngeal nerve. Okay, you see the glossopharyngeal nerve is coming all the way and it is supplying the areas of the pharynx. Okay, it is supplying the areas of the pharynx. So whenever you want to check the gag reflex, what you do, you put the uh, throat swab, touch the swab pharyngeal wall here, and the patient experiences the gag reflex. Okay, like this. Time when the gag reflex is absent or very slow, that shows there is some motor neuron disease. Okay, so these are all the place where you use your clinical knowledge to assess the patient. Okay, so this is how the glossopharyngeal nerve is distributed. This is how the glossopharyngeal nerve is distributed. Okay, now let's go to the next cranial nerve. Let's go to the next cranial nerve. That's the vagus nerve. Vagus nerve said to be the longest cranial nerve. Vagus nerve said to be the longest cranial nerve, and it's the 10th cranial nerve. It's the 10th cranial nerve, and you know this vagus nerve is supplying the organs of respiratory system. It is supplying the organs of circulatory system. It is supplying the organs of digestive system. It is supplying the organs of urinary system, and it is supplying the organs of reproductive system. That means what? The nerve starts in the cerebral peduncle and the branch is extending till the tip of the scrotum, not the scrotum actually, the genital areas. Okay, so this is said to be the longest cranial nerve, and it's a mixed nerve and it's a parasympathetic nerve. It is supplying pharynx, larynx, organs, glands, blood vessels, thorax, and abdomen. Okay, so the main function of this nerve is to do intestinal movements and glandular secretions. Glandular secretions. So now we will trace that nerve and see branch by branch. Okay. Okay, this is the place where the nerve, vagus nerve is coming. Okay, here you can see. Okay, this is the origin point of the vagus nerve. This is the origin point of the vagus nerve. It is coming, exiting out through the uh, base of the skull. Okay, so it is mixed nerve. It is having sensory fibers, motor fibers, and also autonomic nervous system fibers. It's also having the autonomic nervous system fibers. Okay, it's coming out of the skull through the jugular foramen. Okay, the jugular foramen is present. This is the jugular foramen, and it is this is the place where the jugular nerve is coming out. Along the jugular foramen, the vagus nerve is coming out. Okay, and then it is coming out with the carotid sheath. It is coming out with the carotid sheath. What is this carotid sheath? You know what? In the neck, there is a sheath where, okay, okay, I will show you the carotid sheath. Okay, if you cut the neck, if you cut the neck, let me draw and explain you. If you cut the neck, here you have the vertebra, you have the vertebra here, you have the transverse process and the vertebral body. Okay, then you have the trachea here and the esophagus here. Okay, now if you look at the deep cervical fascia of the neck, so there is one fascia just under the around the neck, that's called as investing layer of the deep fascia of the neck. Investing layer of the deep fascia of the neck. So Around the vertebra, there is one fascia that is called as prevertebral fascia. Okay, around the trachea, there is a fascia that's called as pretracheal fascia. By the side, there is a circular fascia that's called as the carotid sheath. That's called as the carotid sheath in the right side and left side. In the carotid sheath, you have the jugular vein, you have the internal jugular vein, and you have the carotid artery, and you have the carotid artery, and also you have the vagus nerve. This is the vagus nerve. Okay, so this sheath is called as the carotid sheath. This sheath is called as the carotid sheath. Okay. In the carotid sheath, you have the internal jugular vein, carotid artery, and the vagus nerve. Okay. So these deep fascias of the neck are starting in the. Imagine this is a mandible bone, and this is a rib cage. This is a rib cage. So these fascia they start in the base of the skull and come all the way down, go and end in the mediastinum. That is the space. Okay. Likewise, the pretracheal fascia, it is starting around the trachea and it is going and ending in the mediastinum. In the mediastinum. Likewise, the carotid sheath, it is starting in the neck base of the skull and it is going all the way down to mediastinum. So why I am telling about this deep fissure of the neck? Because in case if there is any retro abscess formation here, what happens? This abscess it keeps draining all the way down, and it goes and collects in the mediastinum. Okay, so when there is retropharyngeal abscess formation, more amount of abscess is collected in the mediastinal space. Okay, but here it appears very small. When you drain, you can drain around 1 to 1.5 liter of abscess, that pus, when you make the patient lie down. Okay, so these are all something clinical area that I don't want to go into clinical area. Just you have to know that the vagus nerve is passing through this carotid sheath. Okay, all the way down here like this. Okay, fine. So let's go to the other application. Okay, now what you see here is the vagus nerve. What you see here is the vagus nerve. Okay, if you look at the branches, this vagus nerve is going all the way down. Okay, the first branch is the recurrent laryngeal nerve that is the larynx. The first branch is the recurrent laryngeal nerve that is supplying the larynx. You can see the branches here. Okay, these are all the branches. Okay, this is the superior laryngeal nerve, and this is the pharyngeal branch of the laryngeal nerve. This is the pharyngeal branch of the nerve, and this one is the superior laryngeal nerve. Okay, and this is the pharyngeal plexus of the vagus nerve. Okay, so this is the superior laryngeal nerve. Okay, this the laryngeal nerve first branch, it is going to the pharynx. It is going to the pharynx, and then it is supplying the vocal cord. So when there is damage to the recurrent laryngeal nerve branch, this can happen when there is surgery in the neck region. Okay, so then the patient loses the speech function. Okay, so that is due to vocal cord paralysis. The vocal cord in the lung, the vocal cord in the lung. Okay, I'll show you. So not in the lung, in the respiratory passage. Yeah, what you see here is vocal that is present in the post aspect of the thyroid cartilage. Yeah, this is the vocal cord. This is the right vocal cord, and this is the left vocal cord, and you can see this vocal cord is oscillating when the speech production is present. Okay, this vocal cord is oscillating when the speech production is present. I would like to show a video how the vocal cord functions. Okay, so what you see here is the vocal cord function. You can see how the vocal cord is oscillating according to the sound that is produced. So this is how the vocal cord is oscillating. This is how the vocal cord is oscillating when the sound is produced. This is how the vocal cord is oscillating when the sound is produced. So this is the importance of vocal cord. So this vocal cord is innervated by the recurrent laryngeal nerve, and it is the recurrent laryngeal nerve of the vagus nerve is supplying this vocal cord. Okay, this is how the when there is paralysis of the recurrent laryngeal nerve, there is loss of speech. Okay, so this we understand the important function. Apart from this, we can see there are many branches for the vagus nerve. There are many branches for the vagus nerve. Okay, so now we can see the branches. You can see all these branches. Okay, now we can see, as I told you, it is supplying the respiratory passage, respiratory system, and this is a laryngeal branch of the recurrent laryngeal nerve. This is the branch that is supplying this is the branch that is supplying the vocal cord. Then it is coming to the uh, mediastinum. It is passing all the way down to mediastinum, and it is supplying, and it is forming the different plexus. For example, the parasympathetic nerve that is supplying the digestive tract. Okay, if you look at uh, this autonomic nerve distribution, the vagus nerve that is supplying the uh, respiratory trachea, then the stomach, then the small intestine, liver, pancreas, kidneys, then small intestine, large intestine, all these places, this vagus nerve is distributed. The vagus nerve is distributed. Okay, so so that's why it is said to be one of the longest cranial nerve. Even for the heart also, this vagus nerve is supplying. I will show you the branches that is supplying the vagus nerve. I will show you the branches that is supplying the vagus nerve. Um, okay, these are the vagus nerve branch. These are the vagus nerve branch. Okay, here you can see these are the cardiac plexus. These are the coronary plexus, which from the vagus nerve, which is branch from the vagus nerve. You can see these branches are controlling the speed of the heart. Generally, when this nerve stimulates, it will reduce the heartbeat. Okay, so whenever you massage the carotid triangle in the neck, what happens? You can see there is sudden drop in the heartbeat. That is due to this vagus nerve, that is the parasympathetic nerve, will reduce the heartbeat, whereas sympathetic nerve will increase the heartbeat. Okay, so this is the coronary plexus nerves that is supplying the heart, and it will reduce the speed of the heartbeat. Okay, so this is what you have to understand about the vagus nerve. Now let's go to the next nerve. We have finished with the 10th cranial nerve. Then the 11th cranial nerve is the accessory nerve. Okay. This accessory nerve is supplying the trapezius muscle and the sternocleidomastoid muscle. Okay, the accessory nerve is supplying the trapezius muscle and the sternocleidomastoid muscle, and this is a trapezius. This is a trapezius, and if you look at the nerve supply of this trapezius nerve, you see this. If you have to watch this carefully, you have to observe this carefully. This is the trapezius, large muscle in the posterior aspect of the body, and you see this accessory nerve, it is coming out of this cranial cavity in jugular foramen. Then and two nerve, this is a C2 nerve branch, this is a C2 nerve branch, and this is the accessory nerve. So when the C2 nerve branch comes and joins to this nerve, it takes the name as spinal accessory nerve. It takes the name as spinal accessory nerve. So this nerve is going all the way, and it is supplying the trapezius muscle and also the sternocleidomastoid muscle in the neck. Okay, and also the this is a sternocleidomastoid muscle. If you look at the nerve supply here, okay, fine. So here the same nerve is supplying, the same accessory nerve is supplying this sternocleidomastoid muscle. So this is the function of this 11th cranial nerve, that is accessory nerve. So what happens, the accessory nerve comes out of the cranium, and then it has some then one and joins with this accessory nerve. See, this nerve is C2 nerve is coming and joining the accessory nerve, C2 C3 nerve, and then it is changing the name as spinal accessory nerve, and this nerve is supplying the trapezius and the sternocleidomastoid muscle. Okay, next you have the hypoglossal nerve. So the hypoglossal nerve, that's the 12th cranial nerve that is supplying the muscles of the tongue. The 12th cranial nerve that is supplying the muscles of the tongue. So this tongue muscle is okay. Here it is present here. Okay, I will remove the map. I will remove the multiple. Then I will show you the tongue. I will show you the tongue. Okay, what you see here is a tongue. This tongue is innervated by this hypoglossal nerve. Okay, the tongue is responsible for changing the pitch of the voice, then chewing the food and all this stuff. Okay, so if you want to see the hypoglossal nerve, okay, so this is the hypoglossal nerve. This is the hypoglossal nerve that is coming and distributing in the and supplying the muscles of the tongue. Okay. So by this okay, so as I told you, the order is important: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, then facial, vestibulocochlear, glossopharyngeal. Okay, these are all the nerves that is present originating inside the cranium and taking. It doesn't matter where it is ending. It is ending inside the cranium or it is ending outside the cranium, that doesn't matter. So since it is originating inside the cranium, we call them as cranial nerves.